that we have this panel put together to talk a little bit about why we should care about mental health when we're talking about adolescent health. I'll just briefly, my name is Carly Silver. I lead the programs at Grand Challenges Canada. And over the last 6 years, we've invested about $42 million into different mental health innovations that increase the access to care and effectiveness of treatments for mental health in low and middle income countries. About 30 different countries, about 85 different projects, and we've seen a number of those be really focused on adolescent health. And some really innovative ways of essentially cracking the problem of how is best to reach adolescents where they are with the right kind of messages, the right kind of people delivering those messages, and actually contributing to adolescents' well-being as they go through this important transition in their life. Thankfully, I have a great panel that's going to help me elucidate that a little bit more. So I'll do a really brief intro and then we'll get into the action here. So first of all, I have Dr. Shekhar Saxena, who is the head of mental health and substance use disorders at the World Health Organization. I've got Teresa Betancourt, who's at the Harvard School of Public Health. I've got Arun Ravindran, who's with the Global Mental Health Affairs at the University of Toronto and CAMH. And then I've got Bethel Klilu, sorry about that, who's one of the youth council members for the conference and also works at Sick Kids and has got some great lessons to be talking about her work as a peer counselor. So Shekhar, I would love to have you kick us off and talk to us a little bit about how common mental health disorders are during adolescence, and why do we say that we actually can't have adolescent health without focusing on mental health?
Good morning to all of you, and thank you for inviting me. Let's talk mental health, and let's begin to talk mental health with some facts and figures. Is mental health important for adolescents? We have the measure of DALYs, which is disability adjusted life years lost, and if we look at this chart, we see that there is a lot of burden because of non-communicable diseases during adolescence, as well as mental, neurological, and substance use disorders. 21% of the burden in adolescent is because of these disorders, and 41% of the total NCD burden is because of these disorders. And here is a breakup of that. Mental substance use in the blue part is the largest. Neurological disorders behind that, and self-harm behind that in terms of the overall DALYs. However, when we come to deaths, these percentages are there still. 9% of deaths in adolescents is because of MNS disorders, and 32% of all deaths because of NCDs are because of these disorders. What is quite important is to contrast here now that self-harm is responsible for many more deaths in the adolescent period. In fact, in many countries, it is either the largest or the second largest cause for death amongst adolescents, but neurological and self-harm and mental disorders are also there. Key points: second most cause of death between 15 to 29 years of age, partly is adolescents, and the most common cause of death in girls, 15 to 19 years. This can no longer be ignored. We need to count that. We need to look after that, and there are many methods that can be used. Carly, you asked me the second point, what could be done about that? Having seen the figures, there's a lot that we can do. It has already become a priority for WHO. I work for WHO. It was not a priority till 5 years back, but it is now very much so. And as a part of adolescent health, mental health is a very important component for us now. The focus should be on prevention. As we have heard this morning, several speakers saying, 50% of all mental disorders arise before the age of 15 years, and almost 80% before the age of 25. Those are very high percentages. We need to focus on prevention. Prevention of depression, prevention of anxiety, prevention of suicidal attempts, and suicidal deaths. And again, we have very clear evidence-based interventions that can be done. Second, promotion of mental health. It's not only important to focus on those people who are at high risk. The focus should be on every adolescent, because there are resilience, there are other things that can be done to promote mental health, which will have various outcomes in terms of behavior, in terms of other non-communicable diseases, in terms of HIV, in terms of risk-taking. All of those are important. And lastly, for treatment. For those adolescents who have a clear mental health problem or a disorder, we need to find a way to provide help. And we know that adolescents are not very keen to walk into a clinic. So we need to find innovative ways of doing that. Some of them are, one, to integrate it within the overall healthcare system, whether it's for HIV, whether it's for sexual counseling, for other things. We need to integrate mental health there. Second is alternate methods. Self-help is very important, giving them online access by electronic and mobile means which they can access is extremely important. And we are now developing in WHO methods for self-help as well as for electronic and mobile methods by which adolescents can be reached. So we are now becoming active. We hope to be doing much more, and we appreciate Canadian leadership in this area. Thank you, Carly.
Thank you very much, Shekhar. So you mentioned a little bit about the need for innovations, and especially tackling the promotion part and the prevention part of mental health equation, as well as the treatment. And Teresa, you've been working with some groups in West Africa around this issue, and especially with adolescents who are have not only gone through the normal kind of adolescent tumultuous period, but also have been doing this at a time where their whole society is dealing with kind of post-conflict situations and stuff. So tell us a little bit about these boys and girls that you're reaching.
Sure. So our work in Sierra Leone grew out of a longitudinal study, actually, which we began after the war in 2002, where we've been tracking the lives of 529 young people since they were ages 10 to 17. And we've had data collection in 2002, right after the war, 2004, 2008, 2016, 2017. It's now become an intergenerational study. And we're looking at these young people as parents and in young adulthood. And really looking at factors that shape outcomes related to resilience as well as risk, especially with attention to mental health. And we, in this longitudinal study, learned a lot about the impact of things that you would call toxic stress exposures. Sexual violence, which affected more than 45% of women in our sample, 5% of boys, being involved in hostilities and the impacts on emotion regulation, feelings of hostility, death of a parent being associated with anxiety and depression, as with sexual violence. But we also learned a lot about the post-conflict environment, and that for young people many years after the war who are on more dangerous trajectories, not being able to get back into school, having low levels of social support, having interpersonal difficulties, stigma, and difficult relationships with the community were particularly troublesome and predictive of poor outcomes over time. And we realized that in doing observational research, that was one thing, but we couldn't just stop there. And we had to think about the obligation to take from this research to think about intervention models that could be safe, effective, feasible, and deployment focused for use in low resource settings where we have very little to work with, and a health system that's decimated first by the Civil War and now the Ebola outbreak of 2014-2015. And so that led to some formative work that we did around youth mental health services and the possibility of what could be feasible, effective, and safe. And so we looked at the context and realized one of the realities we had to deal with is we have a country of 6 million people, post-conflict, post-Ebola, with one quasi-retired psychiatrist and a handful of mental health professionals. So we'd have to think about models that involve task sharing and also group work, which builds on the collectivist culture. Also that young people in our research, when we look at war-affected youth, they don't just present with clean depression or traumatic stress reactions alone or conduct problems alone. They're often comorbid or co-occurring, which means we have to think about transdiagnostic interventions that can't just target single disorder categories. We have to think about what's evidence-based to address a range of different problem areas. And then third, we can't do standalone mental health. We saw the importance of getting back into school for young people who are war affected. So we have to think, like Shekhar just said, about creative, innovative platforms for accessing these services, getting these services to young people. So in addition to integrating them in the health system, integrating evidence-based mental health interventions into school programs and into youth employment programs. And this was the genesis of what we call the Youth Readiness Intervention, which came out of that formative work. We reviewed the literature on what are evidence-based practices for youth exposed to violence and maltreatment in higher resource settings that have been tested in low resource settings that have potential to go to post-conflict, Ebola-affected Sierra Leone. And we settled in on these 6 components that were feasible but also had a strong evidence base and seen as something that could be done by lay workers with excellent training and excellent supervision. And so this involves psychoeducation about trauma and its effects on your sense of self, your relationship with others, emotion regulation skills for those young people who, when triggered, have a difficult time responding well, and helping them develop coping strategies that work for them that they can use, cognitive restructuring to challenge their negative sense of self and their sense of the world around them, and then, as Shekhar mentioned, behavioral activation, which has a strong evidence base for the treatment of depression. And once we have those stabilization sort of elements built, we can then start to work on some of those interpersonal skills using the groups to practice how do you present your best self. And then finally, problem solving, setting manageable life goals and moving towards them in small steps, which is really critical for helping young people who want to finish school or secure a livelihood. And I can tell you a little bit about what we've learned, but we completed a trial that was published in the Journal of the American Academy of Child and Adolescent Psychiatry in 2014. And we looked at the effects of this intervention in 436 girls and boys following the UN definition of youth, ages 15 to 24. And we compared young people who went directly to a school program. So here is a typical school program for children living in poverty, youth living in poverty in Sierra Leone. You see it's an extremely overcrowded classroom. If you're a young person with emotion regulation difficulties and interpersonal deficits because of the trauma you've experienced, it's very hard to perform well. This school is free, but what they expect of you is excellent attendance, excellent behavior, and excellent effort. And young people who've been through severe trauma and loss can't always pay those fees. And so we found when getting the readiness intervention before going to this program, people in our trial, young people, girls and boys, showed significant improvements in daily functioning, which is critical. They could carry out their day-to-day responsibilities better, interpersonal attitudes and behaviors, emotion regulation, so when triggered, being able to react better, and a sense of social support. And not only did we find those effects, but when teachers rated these young people and didn't know who had gotten what intervention, just going straight to the education program or getting the readiness intervention, we found an effect on teachers reporting better attendance, better attitudes and behavior in the classroom. And so that led us to then, with Grand Challenges Canada, start to test this within youth employment programs. So there's a trial, the data we're just now starting to process, where we randomized young people to getting just a cash transfer with some supervision around how to use that cash, or having the readiness intervention before getting the cash transfer. And we're seeing from the qualitative data, again, reports from supervisors that these young people are showing increasing engagement, retention, and better participation in the program. And the young people themselves are saying that this opportunity to focus on their interpersonal abilities, their emotion regulation, really led to them to do a better job in taking up that life opportunity. And so I think the real promise that we have in this field is thinking of these alternate delivery platforms, getting beyond just the health sector, but to think about education programs where evidence-based mental health interventions can be integrated, or youth employment programs where evidence-based mental health programs can be integrated, and then starting to ask these implementation science questions about what is the impact, what's it going to cost to do these things? What are the training and supervision structures? And how can we study how to look at those elements that will allow us to go to scale and sustain quality, and then create materials that can be handed over to development partners, to governments, and to other stakeholders to arrive at sustainability.
Great, thank you. And Teresa, I know you have some interesting work about, you mentioned initially the stats around how many of the girls versus boys had experienced sexual violence before, but be interested to come back if we've got time, on how you really looked at the gender element of your treatments to ensure that you were actually getting impact on both boys and girls. Yeah. We'll leave it there for a second. Okay. We'll come back to you. And I'd love to hear from Erin, and you were also looking at how do you use different platforms to be reaching adolescents and in Latin America. And please tell us about the youth that you were reaching through the school programs in Nicaragua and Guatemala.
So the project I'm going to talk about is the idea is to use a mental health curriculum to improve the mental health knowledge of transitional youth, essentially those between 15 and 21 range, and thereby improve their function and to prevent occurrence of mental illnesses, as this is the age during which a lot of the youth start experiencing the mental unwellness for the first time. A little bit about Nicaragua, where this project was carried out. We did it in a university town called Leone. As you probably know, Nicaragua is one of the poorest countries in the Western Hemisphere. A third of the population live on less than $2 a day. Out of the population, about 50% are under the age of 24. So the adverse social determinants are rampant, including violence, natural and man-made disasters like the war, poverty, which have significant impact on the population. Mental health care is virtually non-existent. There's one psychiatrist for 150,000 population and one mental health nurse for 200,000 population. There's no specialized services for youth. So that's the scene where we went into. So what we did was, in collaboration with Dalhousie University and University of Leone, Nicaragua at Leone, we implemented a mental health curriculum, which was previously evaluated in Canada and several other countries. The project was funded by Grand Challenges Canada, acknowledged. And so the idea was that we would do it as an intervention as well as a clinical trial, where we would have an intervention group of approximately about 500 students in the final year of their high school and first year of university, and a control group of about 400 students. We would train the intervention group teachers in mental health curriculum over a period of 3 to 4 days. And the didactic component of the curriculum was complemented by a web-based program where the students could access anytime and communicate with their peers, ask questions, and clarify issues. So the idea is to see whether the schools could be developed as mental health hubs and create the prevention as well as support program. It was very gratifying to see that using standardized instruments, we were able to show, and the instruments included those that measured quality of life, coping ability, stress perceptions, reduction in symptoms, reduction in addictive behavior, etc. We found that there was a significant difference between the intervention group and control group. And in the control group, after they finished this part of the study, they went into active treatment and they were evaluated as well. Overall, we trained, about 1,000 students benefited, and we trained close to 125 teachers. You can read the comments on the subsequent feedback group sessions from the youth. It was very gratifying to see the impact that seemed to have had on them, particularly relating to stigma and the fear of mental illness and ability to relate to those who suffer from mental illness. We also got some feedback as to what could be done to improve, and we got some really good feedback. And there was a very strong kind of request from the students and the teachers that we should include components focusing on positive youth development, developing cognitive skills, communication skills, and being able to develop leadership skills. They also wanted us to address addictions in a more detailed way, and to address social conscience issues, including gender-based violence, gender discrimination, prejudice, homophobia, and these issues. So again, with a grant from Grant Challenges, we have started implementing the program as a scale-up in Guatemala City in collaboration with University of San Jose. And we have incorporated this component and hope to see how it evolves.
That's great.
Thank you.
And you also, I am also going to come back to you in a moment to get a little bit more into the differences you saw between boys and girls, as I think this is something to pay attention to as we go forward, to make sure that we're actually reaching all adolescents and making sure that some of these differences that are innate to boys and girls are actually being dealt with as we deal with this problem. Bethel, I'd love to turn to you. You've got some great lived experiences, both in Canada as well as in Ethiopia, and the work that you've done there with youth in both of those places. And would love to hear from your perspective on kind of what are the similarities and differences that youth in these two places are really tackling, and how you've interacted with them.
Yes. So just before going into my experiences, it's really important to note that youth experiences and youth mental health, adolescent mental health, is not a homogeneous experience. Their experiences, the way that they perceive their health is very different. And we really do need to take into account social determinants of health, intersectionalities between gender and race and income and housing. So even though I'll speak about my personal experiences in terms of frontline work, I can't speak on behalf of all youth and adolescents. But in terms of Ethiopia, I went when I was 21 to just work with youth, both in the capital of Addis Ababa, but also in rural areas as well, and just coordinating and co-leading empowerment workshops. And I noticed that when I went to Debre Birhan, which is more of a rural village in Ethiopia, I came in with my own perspective. I was born and raised in Canada, but my family, my family is from Ethiopia, so I assumed that I had a good understanding of what adolescent girls needed and wanted, and what their expectations were. And I realized coming in, I had my Western thinking. I came in with my assumptions of what I thought they wanted. So our group assumed that body image, for example, was something that they really cared about, that it was a concern in terms of their self-esteem and mental health overall. And then halfway through, we realized that they really didn't care about body image. They had other needs and other things that they cared about that were more important. So considering that they are of a lower income, they cared about things like food and nutrition and clothes, just basic needs. But they also really cared about their relational needs. They cared about their relationships with their families. They cared about their relationships. Well, I was speaking with girls, so they really cared about boys. And we really had to pause and understand the complexities and addressing their concerns. In terms of Canada, I coordinate peer education programs at the University of Toronto. So I work with youth in the Canadian context, and their needs are very different. Their concerns are very different. I'm constantly aware of the fact that anxiety and depression are growing concerns, that they have suicidality. I think I know friends of friends who've committed suicide. It's something that's fairly common in our context. The lack of resiliency is also something to note, that although youth here, adolescents here may have access, they have better housing or a higher income than those in lower income countries, they are still dealing with mental health concerns and mental health issues that are very distressing, to say the least. And even within this context, there's still a great deal of stigma. So even when an adolescent or a youth or young person is at the point where they're ready to address those concerns, they're having a hard time finding services and resources to help them. So just to say the least, I think those are some of the main concerns that I've noticed in my work.
Great, thank you for sharing that. So I'd love to return to this question, and Teresa, maybe just tell us a little bit about how you looked at tackling this issue of girls and boys maybe having different needs, but both having the need of mental health.
Right. Well, especially when you start to work in other sectors, sometimes there's an equal sign when you say youth with young men. We've had that problem in youth employment a great deal, where we had to really advocate with government and development actors that youth employment opportunities should be equally accessible for young women and for young men. So in developing the mental health interventions to link to youth employment, we recognize that the life circumstances and the sort of interpersonal issues in particular that young women and young men may be working through are going to differ. And so the groups are by gender. We have younger girl groups and older girl groups. And because we're looking at high generalizability, we have groups for girls who are 15 to 17, and then groups for girls who are 18 to 25. Same for the boys, that we have the younger sort of ages together and the older ages together, and then a same gender facilitator. And in the examples they use, both in the training we do a lot of attention to training and supervision, because with mental health, this is really critical. We focus too much on training, but not enough on supervision. And a lot of content comes out when those groups are running, and we have to be able to have some quality improvement in learning about that. And girls are often struggling with interpersonal issues, decisions around self-sufficiency, issues where they're in situations of exploitation, sometimes even within their own family, in terms of being able to access opportunities to go to school or to secure a living. And we use the groups as a safe space to work through those examples, same for the boys. And the exciting part of the youth readiness intervention, which is basically cognitive behavioral therapy with a little bit of interpersonal therapy in there, which are two very important intervention models with a strong evidence base behind them, is when doing this in war-affected post-Ebola Sierra Leone, we haven't seen a gender difference in the impact or the outcomes. So we do adapt the intervention by gender, but we're still getting highly generalizable results, which is exciting.
It's very exciting. Arun, similar experiences in your work in Nicaragua, different?
Very similar, and I think we didn't find much differences in between the genders either in terms of the benefit and overall kind of positive results were very similar.
That's great, that's great. I'd love to, we're gonna come to the audience to see if they've got any questions in a moment. Before I do that, I'd love to hear from Shekhar and from Bethel in terms of, speaking to this audience and to, these are people who are programmers, who are people of influence about where the world's gonna pay attention in the coming years around the health agenda. And what would be your ask to them? What action are you really looking to see when it comes to enabling mental health in adolescence?
Thank you, Carly. Two things. One, we need to see to it that help is available in a non-stigmatizing way and non-stigmatizing environment. And you can help, because when you work in your programs, you can see to it that mental health is not segregated. It's integrated within the health and development agenda, so that we don't talk about people with mental disorders versus other people, because that will be very damaging and will decrease access. That's important. The second thing which I did not say in the beginning was also use of drugs and alcohol, which is a major problem for adolescents, which leads to problem of its own as well as other mental health issues. And that's something, again, which need to be focused. And again, you can help, because you are running some programs, and you can see to it that these educational efforts are integrated within all the work that you do.
Great. Bethel?
So I have 5, actually, actions. So I'll try to be really quick. So the first one would be having a youth-centered approach to programs and services, and to respond to the needs of youth. So in my context, I went to WWHUN, and I thought, body image is the thing, that's what I need to address, realized that was not the case and quickly adjusted. So I think it's really important that programs and initiatives, when they notice that something's not working or if they're not meeting the needs, to pause and just adjust and change directions, as opposed to trying to continue with a path that's not really working out. Second, youth need to be at the table. And not in a tokenistic way. We really do need to have youth voices centralized if we are trying to address youth health or adolescent health, specifically when it comes to mental health due to the vulnerable nature of the condition. Third, services need to be accessible. I had a friend of a friend tell me that she needed to schedule her breakdowns in advance so that she knows she'll be able to see a counselor, just because of the wait times associated with counseling and those types of services. So we really do need to do better in terms of having accessible services for those that are of lower income, who don't necessarily have the resources to see a psychiatrist or to see professionals in that way. So really investing in creating jobs for counselors, programs for counselors, for communities as well as schools. So we're seeing mental health concerns starting in childhood, so there really needs to be more work in that regard. And then fourth, promoting peer education programs. So youth usually feel more comfortable disclosing to other youth. So we need to train young people to be able to recognize, respond, and refer, so that they can be an asset to their own peers and their own community. And then lastly, we need to promote free or at least subsidize the cost of online or mobile services and helplines. Sometimes it may not be realistic right now to just have millions of counselors on the ground, but there are great apps out there, there are great services, and we really need to support them so that they can get the word out. There are so many young people with cell phones all the time, so that's at least a way for at least providing some short-term cognitive behavioral therapy if necessary. So yes.
Great, thank you for those. So I'd love to open it up to see if there are any questions and comments, and also invite others who, I know we've got some real Canadian strengths in terms of dealing with mental health, and so please do share if you've also been incorporating mental health into your own programming. We'd love to hear about it. Zulfi.
So, great session, and I'm Zulfi Bhutta from the Center for Global Child Health in Toronto. So Teresa, a question for you, and then I have a comment. So the question pertains to absolutely phenomenal work that you've done in Sierra Leone. So what can you tell us from that longitudinal cohort, that unique cohort, in the context of sensitive age periods in terms of intervention? So as you heard me say this morning, some of us who have looked at the evidence are impressed by how much can be done still within the adolescence period. So it's not a period without plasticity. But is there any data from that cohort to indicate that there is greater gain by going in early, and if so, what that is? And if you could say a word or two about particularly child soldiers in that context. So what has been the experience of those who have active first-hand experience of being in the middle of the conflict as opposed to being bystanders and having observed this? And Shekhar, my comment relates to the whole issue, the real challenge of mental health intervention. So I completely support the notion of bringing this in, particularly for the big ticket items like, suicides and parasuicidal activity. But I think what it also behoves us is not just to track that as indicators, but to also at the same time have an eye on services that are available, strategies for interventions. And if one looks at that particular balance, we have, even in relatively well-established health systems, very, very poor services for adolescents and young adults. Even in this country, for adolescents and young adults with mental health services, there are people who drop through the cracks because the current health system coverage does not support them. They either have to have deep pockets or their parents have to have deep pockets to support them. So leave alone what happens in LMICs, low and middle income countries. So I'd love to hear your views on how can we take both forward? Because in my opinion, measuring without provision of some services or at least getting those on the ground are really ethically very challenging issues.
Great. We're going to take a few more, so hold your responses, guys. We'll see how many we can retain. On this side?
Hi, my name is Jennifer, and I'm originally from Guyana, and in 2016, Guyana was actually the country with the highest suicide rate in the world. And so my question is kind of twofold, and I'm wondering if you can speak to some of the macro issues that are affecting mental health. Is it because of a lack of development, a lack of opportunity, in your experience? And secondly, I'm just kind of wondering, now that the global agenda is turning towards addressing mental health, how do we prevent the imposition of Western interventions, of care, and just those Western concepts alone?
That's great. Thank you. We'll take one more, and then we'll go back to the panel so we don't have to retain too much. Go ahead.
Sure, Caroline Riseborough from Plan. Just thrilled to see this panel, particularly because I worked at CAMH for a little while, but we wouldn't have had this kind of panel, let's say 5 or 10 years ago. I heard a few people say there's no health without mental health, and yet there is still this perception in international development that mental health is a luxury compared to other areas of health. There's a number of large implementing NGOs that are represented here, spending billions of dollars, both of government funds, from the largesse of Canadians, and yet there's very little work among us on the areas of mental health. So I'm curious what you think we need to do to change that and really ignite more work around mental health if we truly believe there's no health without it.
Great. So a few things. So let's do a line down here, and then we'll grab a couple other questions if we have time. So Shekhar, do you want to go first?
Thank you. I respond to 2 of the questions about measuring and capacity building. Yes, both need to go together. Measuring is very important because otherwise we will not know what the problems are and how well we are dealing with that. But that needs to go with capacity building. I have written it earlier and I'll repeat it here. When it comes to mental health, no country is a developed country. We truly need to believe that, and we really need to work on that, even in so-called developed and high-income countries, because people fall through the cracks all the time. And sometimes it's from the countries like Sierra Leone and Nicaragua that we can learn a lot as to what to do in Canada. And I mean it when I say that. The countries which have less resources are innovating much more than some of the high-income countries. And there is always a bi-directional exchange of information which will help us a lot. The second issue, there should be no health without mental health, and there should be no health program for adolescents without a mental health component. So when you write the next grant, when you negotiate for some more money, see to it that mental health is an integral part of it. Thank you.
Teresa, you had one specific question, and then feel free to reflect on it.
Sure, just to pick up on what Shekhar just said, I think in working with the World Bank more frequently recently, they're finding that the countries where their development assistance isn't going as far are countries that have been through conflict and humanitarian issues, and that if you don't address the mental health components of overall adolescent health, you will fail to reach your goals in terms of your investments in development assistance. And if you look at some of our findings and other findings around the impact on daily functioning, so yes, improving symptoms, but also improving the young person's ability to carry out the things they need to do in life, to attend school, to participate in a jobs program. These are critical elements of what mental health interventions can do. And so the development actors have to really, their ears should perk up when they hear that. And that's why our work in Sierra Leone, we talked talked about the stigma issues, to make these more accessible, we're not targeting just child soldiers. We don't find that's helpful. In fact, stigma is one of the more dangerous things that can happen in the lives of a child soldier. So to make these programs broad-based and to use non-stigmatizing language, that's why we call our mental health intervention, which is an evidence-based mental health intervention, the Youth Readiness Intervention. That's intentional to help open up a dialogue with development actors. The Minister of Finance is much more interested to talk about a readiness intervention than a mental health intervention. So thinking about how you communicate these concepts is also really critical. And in terms of the specific question on sensitive periods, we do see for young people in our longitudinal study of child soldiers, those abducted at a younger age showing some risk, especially when it comes to anxiety and depression. But we also see that anxiety and depression is advanced by daily hardships in the post-conflict environment. And so we can't go back and undo those war exposures, but we can do things about the post-conflict environment when it comes to being able to have food security, housing insecurity, get into school, have a job. Those are the things in these highly traumatized populations that we need to be focused on, rather than label-driven programs just for one type of young person, to think about broad-based system strengthening and investments in evidence-based mental health integrated into creative and innovative platforms.
I would fully agree, and the mental wellness framing is very important. I think it appeals across the board, not only to the youth themselves, but to their families and the leadership of the country. More and more we look at, as Sekar mentioned, there is no health without mental health. Similarly, there's no mental health without positive youth development. I think it's overall, we need to ensure that the experiences you'd get are meaningful to them and they learn from it to grow into adulthood in an optimum fashion and to be able to utilize. The second is, I think we need to embrace technology even more. I think one of the reasons why the youth in our project was very interested was the component of the technology component. They were able to go to this mind cloud and able to talk to their peers without losing their privacy and those kind of issues. And the third issue is the whole issue of new sets of addictions. The internet is a great asset, it's also a great liability. And it has contributed, at least in some studies, to negative behaviors, suicidal behavior, etc. So to be able to understand this better, we need more research, more investment in evaluating interventions for these difficulties.
And in terms of, I'm going to combine questions, but the high-level, macro-level issues, as well as the on-the-ground frontline concerns, I think as a community of professionals as well as young people, we need to address both ends of the spectrum. So in terms of high-level agreements, having that consensus between nations or even at the UN on that level of how important mental health is, and that there needs to be a kind of a trickle-down effect in terms of policies, investments, funding for programs, but also in terms of frontline, I believe peer programs are amazing, creating a sense of community so that youth and adolescents can disclose, share their feelings, not feel stigmatized for their stresses and their concerns. Friendships, increase resiliency among young people. So really investing both financially and time-wise on both ends of the spectrum so that we can at some point improve the condition of mental health among youth and adolescents.
That's great. We'll grab one last question, I guess, and then we'll go to wrap up. Go ahead.
Hi, my name is Jumana Haj Ahmed from UNICEF. Thank you very much for the very interesting panel. And thank you for emphasizing the importance of working across sectors. And this was also mentioned in the panel before on adolescent responsive health. My question is relating to existing evidence on scaled up interventions where with life skills-based education being integrated into the schools, into the curricula, and the link to mental health and mental well-being of adolescents. And what does the evidence say? And we know that more and more there is improvement in the quality of education through the integration of psychosocial competencies, decision-making. So just thinking from the prevention perspective and implementing at scale what existing evidence is there. And the second one is, the second question is on the link between the sense of agency and participation of adolescents at home, at school, in their neighborhoods, with their mental health, and how it provides them with the competences to have a better mental health or well-being. Thank you.
So two good meaty topics to end us off with. So Bethel, do you want to start, and then we'll work our way back?
Right, sure. So in terms of referring to school-based or life skills, I think a lot of young people I know, at least, are lacking in that area and really concerned about life transitions, what to do once you finish school, what to do once you've graduated, joblessness, unemployment. And so I think really investing in these school-based programming, investing not only when they are adolescents, but also at the childhood level, in terms of creating that space for resiliency to happen, so that once they reach adulthood, they are able to cope with life in general. Because I think that's something that we're seeing is an issue of just being able to cope with the daily issues of life.
Great. Baron, you built a program that sits in schools. Why'd you do it?
I think there is evidence being built up. There are a number of, there are several publications recently, abstracts on the efficacy of providing mental health education through the school system. Is definitely cost effective. Again, I think the buy-in from the teachers are going to be important. The curriculum need to be adapted culturally well. There should be good buy-in and contribution to the program itself locally. And as Dr. Saxena mentioned, it should be a two-way process where we learn from the low and middle income countries and often utilize that to do work in places like Canada with disadvantaged population. The evidence is there. I think we need to make it more sophisticated, more clear, and look at it objectively.
Yeah, just to follow on that, I think when you come to asking about sense of agency, even in our longitudinal study of war-affected youth, I think that's why we see this resilience finding around staying in school or having access to school. It's related to that trajectory of hope for your future that you're on, and that sense of that you have control over your environment and you can advance yourself. And we use a lot of opportunities in our interventions to have youth advisory boards. We've actually, in working with stakeholders, taken the young people who've been in the youth readiness intervention to have them present at the State House in Sierra Leone. And that's been a very big part of building the political will around this program. And I think having that sense of involvement and ownership for the program is really important. And then when it comes to the evidence around going to scale, I think you said it very well, that we're slowly building. You see a number of papers and publications and trials that have looked at having interventions delivered in these new delivery strategies, either task sharing, where you're using community-based volunteers. We're doing a trial like that within the poverty reduction system of Rwanda with family home visiting, which is a prevention program, looking at can we, through those networks that normally do non-formal early childhood development childcare programs, can those people, community volunteers, do prevention services at the household level for the most vulnerable? And looking at teachers delivering them. Our trial in Sierra Leone is looking at can youth employment workers be the delivery agent for these sorts of evidence-based mental health interventions. But then that's why implementation science, I think, is such a critical area of global mental health right now, because we have to ask really important questions around what is the correct supervision structure? Tough cases are going to come up. Where are people going to go to make sure they're managing those tough situations if they're lay workers who don't have mental health degrees? That it's not just about training, it's about quality and it's about supervision as those interventions go out. Is there a tipping point where it's too much to ask? what are the right types of interventions that lay workers can do, and what are the interventions that need to be passed up to a higher level of care or a different sort of professional? What's appropriate for teachers so that we don't burden them, but that they can still do quality work? So we have a lot of really critical implementation science questions going forward that we really need to invest in rigorous research to answer.
Great. Last 30 seconds to you.
What is the evidence? We in WHO believe that for some of these programs, like life skills education, for example, parents skills training, as well as early childhood stimulation programs, which are of course going to lead to returns during the adolescent period, there is enough evidence to apply it in programs. However, this should be done in a systematic manner and not in a superficial manner. One lesson is not going to help. A program where some of these things are built in with adequate supervision, which Teresa pointed out, as well as evaluation, will be the key. And we do support that. So we believe there is enough evidence to try it out, to scale it up with an evaluation component built in. So we have the facts, we have the figures, we have the numbers. We just go and need to do it.
We need to do it, exactly. So I'm thrilled to have this panel today. Help me thank them for a great panel. I'd also love to say that this isn't the last conversation we even get to have about mental health at this meeting, which is fabulous for those of you who are in the mental health space. It's not common that you'd get multiple panels on the same conference, so we're thrilled that the organizers have elevated this as they rightly should. I know Vikram has a panel tomorrow, and so we'll be able to continue this conversation. So let your thoughts about this mull overnight and come back fresh and ready to discuss some more tomorrow on this. So thank you all.
Excellent, thank you.